Hello, my name is Hannah Kelly. I am a dietetic intern at USJ, and today I will be speaking about a published journal article involving a randomized trial of peanut consumption in infants at risk for peanut allergy. This LEAP study, or Learning Early About Peanut Allergy study, addressed the increasing prevalence of peanut allergies in children as it has doubled within the past 10 years in Western countries. The purpose of this study was to evaluate strategies of peanut consumption or avoidance in infants considered at high risk for peanut allergy. Through a randomized, open-label, controlled trial, outcomes were analyzed to determine whether early consumption or avoidance is more effective at preventing peanut allergy later in life. So, the question here being asked is early exposure or avoidance of peanuts in infants at high risk for the allergy more effective in preventing peanut allergy development later in life? Therefore, our next question must address if methodology can be used to answer this scientific question. The methodology behind this study consisted of recruitment, design, and intervention. To start, 640 infants from the United Kingdom were recruited for this study from December 2006 to May 2009 based on inclusion criteria. To be eligible, infants needed to be at least 4 months old, but less than 11 months old, and have severe eczema, egg allergy, or both. Then, a skin prick test was performed to test for peanut allergy in the infants. The results of the skin prick test divided the infants into 2 study cohorts. 1, negative results, or no measurable reaction, or 2, positive results, or wheal formation on the skin of 1 to 4 millimeters in diameter. Infants that were not eligible to participate in the study consisted of those not meeting the age and allergy requirements we just discussed, or those who had a skin prick wheal of greater than 4 millimeters in diameter. The design of this study was a randomized controlled open-label trial. Infants in each cohort, either negative or positive skin prick test results, were then randomly divided into 2 groups: peanut consumption or peanut avoidance. A baseline open-label food challenge was completed for infants assigned to the consumption group. If a reaction to the food challenge occurred, then infants' parents were instructed to avoid peanuts with their child and were included in the intention to treat analysis. For infants that did not have a reaction to the baseline challenge and had a negative skin prick test result, parents were instructed to provide 2 grams of peanut protein per day as a single dose. For those who had positive skin prick results, parents were instructed to provide incremental doses up to a total of 3.9 grams per day. Moving forward, those infants randomly assigned to the consumption group with no reaction to the baseline challenge were fed at least 6 grams of peanut protein per week until 60 months old. Therefore, to find the answer to the scientific question being investigated, assessments of the infants were completed originally at baseline, as we have already talked about, also at 12 months, 30 months, and 60 months old. The primary outcome being investigated was the proportion of participants with peanut allergy at 60 months of age. This was determined by another oral food challenge. The results of this food challenge found that for those infants in the consumption group, early peanut consumption led to an 86% reduction in allergy at 60 months old for those with original negative skin prick results, and 70% reduction in allergy at 60 months old for those with original positive skin prick results. Also, at 60 months old, mean diameter of skin prick wheals and peanut-specific immunoglobulins were smaller in the consumption group compared to the avoidance group. Originally, between the years 1998 and 2000, guidelines in the UK and United States recommended exclusion of allergenic foods in infants considered at high risk for developing a peanut allergy, as well as in pregnant and lactating mothers. However, as more studies like this one have been done, the majority have shown that avoidance does not prevent the development of IgE-mediated food allergy, which is an example of a peanut-specific immunoglobulin we discussed on the previous slide. In 2008, recommendations for avoidance of allergenic foods were discontinued based off of these studies, and now we continue to investigate further. As you can see from the results in the intention to treat analysis group of this particular study, the peanut protein consumption group had significantly lower percentages of the allergy in the negative cohort, positive cohort, and both cohorts combined. However, it is important to note that although this evidence is promising, it may not be applicable to all infants as all conditions are unique. Further evaluation may need to be made by a healthcare professional that is qualified to deal with allergenic diseases. Do findings support current dietetic practice? Well, they seem to. As mentioned before, the old thought was that delaying the introduction of allergenic foods in high-risk infants until 4 to 6 months old was the most beneficial. However, with studies like this one, the new thought emerging is that early introduction is actually better. In fact, the Academy of Nutrition and Dietetics used this study in particular in one of their articles to discuss these new ideals as well. Feel free to check out the link. Some of the flaws of this study included lack of a placebo regimen, exclusion of low-risk infants, and exclusion of infants with a skin prick test wheel larger than 4 millimeters in diameter. However, it is important to mention that this study did not include a placebo regimen due to the nature of using objective peanut challenges as a primary outcome. For the infant's safety, it was necessary to provide parents with nutrition information of the peanut products being used. One tip for strengthening this study is inclusion of low-risk infants and those with large skin prick wheels, as this would make data more generalizable to a larger population. Additionally, a more specific description of site location would provide readers with a better sense of where data collection and analysis was taking place. Lastly, this study could be improved by following infants past 16 months old to see if the prevalence of peanut allergy changed at all once they were no longer receiving the intervention of peanut protein on a regular basis. Fortunately, there were not any conflicts of interest or bias found in this study. The trial was approved by the National Research Ethics Service Committee and overseen by the National Institute of Allergy and Infectious Diseases. Additionally, the manufacturer of the peanut products used did not contribute to the study design or data collection in order to reduce risk of conflicting interests. Also, as mentioned previously, participants were randomly assigned in order to eliminate study bias. And lastly, informed written consent was obtained from parents or legal guardians of participating infants. This study was definitely worth publishing. Through the use of the Evidence Analysis Library Research evaluation tools, it was found to have a positive quality rating and that the question investigated was relevant and valid, along with the measurements and intervention utilized in the study. The study was also considered a Class A study since it is a randomized controlled trial and free of bias, as we just spoke about. Thank you for taking the time to listen to this journal podcast presentation.